Hello, everybody. Our topic for today is Introduction to Endocrinology, the Hypothalamic-Pituitary Axis. So this is your HPA axis, which stands for hypothalamus, pituitary, and adrenal. Okay, so um, this axis is the interconnection of these three major organs. The hypothalamus usually gives out the releasing hormone or the inhibiting hormone towards the pituitary, and then the pituitary usually produces the tropic or signal hormone asked by the hypothalamus, and eventually which also directs the adrenals, and then the adrenals now um, produces the target hormone. Okay, so in this case, the target hormone is your corticosteroids, no? So the releasing hormone from the hypothalamus is your CRH, or your corticotropin releasing hormone, which tells the anterior pituitary in particular to produce the adrenocorticotropic hormone, which will tell the adrenal cortex to produce your corticosteroids. Okay. And then when there is already increased amount of corticosteroids in the body, this can send negative feedback signals to both the hypothalamus and the anterior pituitary to stop producing those hormones. No? Okay. As far as the type of hormones are concerned, we have generally two types of hormones. If you remember your biochemistry, no? So you have the group 1 hormones. These are your steroids, okay, including also your thyroid hormone, vitamin D, and they are generally lipophilic. The receptors are intracellular, are in the cytoplasm or nucleus, and modulate transcription inside the cells. Whereas your group 2 hormones, these are your polypeptides or amino acid hormones, your proteins and glycoproteins, and including your catecholamines. So generally, these group 2 hormones are water soluble, and receptors are located on the membrane of the cells of the target organs, and effects are carried out through signal transduction pathways. So remember this when we go into the mechanism of action of the different hormones from the hypothalamus, pituitary, and your adrenals. Okay, so let's look at your pituitary gland. So this is your pituitary gland, and in relation to the whole brain, it's very, very small, no? So it's pea-sized, very small, but very powerful. That's why it's also called the master gland, no? Because it produces many types of hormones. Okay, on sagittal section, so this slide shows the relationship between the pituitary gland and your hypothalamus. So if you look at this relationship of structures, you'll see that your hypothalamus is situated just above the pituitary gland. And this relationship anatomically is very, very strategic, no? Because we know very well that it's the hypothalamus that controls the function of your pituitary gland. You can also see that your pituitary gland sits in this concavity, which is your sella turcica, no? Located or protected by your sphenoid bone. Okay, so your pituitary gland consists of the anterior lobe, otherwise known also as your adenohypophysis, which consists of your pars distalis, pars intermedia, and your pars tuberalis. You also have your posterior lobe or your neurohypophysis, which is composed of your pars nervosa and your infundibular stalk. in terms of blood supply, your pituitary gland is supplied by your inferior, middle, and superior hypophyseal arteries. Okay, so your posterior pituitary, okay, produces the following hormones. So you have your oxytocin and your ADH or your vasopressin. Okay, please note that if you look at the structure of your hypothalamus in relation to your posterior pituitary, you'll see that there is a direct connection. No? So there's a direct connection between or from the hypothalamus to your posterior pituitary gland. Okay, and this is the reason why it's really the hypothalamus that produces your oxytocin and your ADH, no, and not your posterior pituitary. Your posterior pituitary only serves as a storage site, and it's the one that secretes, no, these two hormones. Whereas in your anterior pituitary, the anatomical structure is different, no? So there's no direct connection between the neurosecretory cell of your hypothalamus to the anterior pituitary. And that's why it's really the anterior pituitary that produces all these anterior pituitary hormones, namely your TSH, your ACTH, FSH-LH, growth hormone, prolactin, and even your endorphins. Now let's classify your anterior pituitary hormones. So your anterior pituitary hormones are classified according to their structure usually, no? So, and they are grouped together because they have similarities in their structures and also function. So we have somatotropic hormones. These are generally polypeptides. So if you remember your steroids, your types of hormones, okay, so where do you classify your polypeptides? So they are classified under group 2 hormones, no? So under this group, you have your growth hormone, your prolactin, and your placental lactogen. Your placental lactogen is seen only among pregnant women, but it acts similar with your growth hormone. Your glycoprotein hormones are your LH, FSH, TSH, and your HCG. Whereas your POMC-derived hormones are your corticotropin or ACTH and your alpha MSH. POMC stands for pro-opiomelanocortin. No? So your pro-opiomelanocortin is a pro-hormone, no? Which can give rise to your corticotropin and your MSH. Okay. This slide shows you the different regulatory hormones from the hypothalamus and their corresponding effects on the pituitary hormones and the target hormones of these specific pituitary hormones. No? So you have here for your growth hormone, you have your releasing hormone from the hypothalamus. Okay, growth hormone in your pituitary gland, anterior in particular, and the target hormone in the tissues is your IGF-1. You also have somatostatin, which is inhibitory of your growth hormone and also your thyroid stimulating hormone. Dopamine, which is inhibitory to your prolactin. Your corticotropin releasing hormone, which is stimulatory to your ACTH. And the target hormone is, of course, your cortisol or your corticosteroids. Your thyrotropin releasing hormone, which stimulates your TSH and your prolactin. The target hormone is your thyroid hormone, specifically for your TSH. And you also have your gonadotropin releasing hormone from the hypothalamus, which stimulates the production of your FSH, LH. And the target hormones are the following: estrogen, progesterone, and your testosterone. Okay, this slide shows you the different cells, no, that produce specific pituitary hormones and their functions. No? Okay, so you just review this slide. Now let's go to your somatotropic hormones. So these are your growth hormone and your prolactin. So let's talk about the growth hormone first. So this is a single polypeptide chain of 22 kilodaltons with two disulfide bonds which are not glycosylated. So the gene resides on the long arm of your chromosome 17. It is known to be the most abundant anterior pituitary hormone, and it is secreted in pulses. No? So there's increased secretion among children, especially at night, shortly after onset of deep sleep. And it also peaks at puberty. So that's why you have growth spurt, no, during puberty. And of course, there's increased secretion in children because they are growing up. Okay. Okay. So the stimulus for your growth hormone is mainly from your, of course, growth hormone releasing hormone from your hypothalamus and ghrelin. Okay, so you remember ghrelin. So what is ghrelin? So ghrelin is an amino acid peptide, no, which stimulates the growth hormone secretion through its action on GPCR. Okay, and ghrelin is synthesized predominantly in endocrine cells in the fundus of the stomach, but is also produced at other sites, including your pituitary and your hypothalamus. Minor stimulus for your growth hormone are the following: dopamine, 5-HT, alpha-2 receptor agonists, hypoglycemia, exercise stress, emotional excitement, and ingestion of protein-rich meals. Okay, so all these things, okay, will increase the production or stimulate the production of your growth hormone from your anterior pituitary. So the mechanism of action is mediated by your GPCR through GS, which increases your cyclic AMP and calcium, resulting eventually to your growth hormone synthesis. So the major peripheral effector of your growth hormone is your IGF-1. So IGF-1 or insulin growth factor 1 is produced locally by many tissues and it functions for growth. Okay? So it is produced by tissues in response to the presence of growth hormone. There are also growth suppressors, no, or inhibitors. And these are the following: IGF-1, somatostatin, and growth hormone levels itself. No? So meaning that if there's increased levels of your IGF-1 and your growth hormone, this will send a negative feedback effect, huh, to the hypothalamus. Okay, so let's see the next slide. So you see here that, okay, your growth, IGF-1, if this increases, will send negative feedback effect, no, both to the anterior pituitary and also to the hypothalamus, okay, to suppress the production of the releasing hormone and production also of the growth hormone by the anterior pituitary gland. You can also see that growth hormone itself, no, will also send negative feedback effect to your hypothalamus if it increases. No? Um, Whereas you can see here that your growth hormone, releasing hormone, that has the stimulatory effect on your growth hormone. But there's another one which is inhibitory to your growth hormone from the hypothalamus itself. It's your somatostatin, no? So your somatostatin will send inhibitory signals both to the hypothalamus to stop the production of your growth hormone, releasing hormone, and also inhibitory effect to the anterior pituitary. So this is how your growth hormone is being regulated. You can also see here ghrelin, no? So ghrelin has a positive or stimulatory effect on your production of your growth hormone by the anterior pituitary, as well as a positive or stimulatory effect to the hypothalamus. But see, it also has a negative or inhibitory effect to your somatostatin. Okay, what are the physiologic effects of your growth hormone? The main effect, no? So which is the most striking physiologic effect is of course stimulation of longitudinal growth of bones, no? Because this will make you become taller. Okay, other effects aside from longitudinal growth of bones, you can also have increased bone mineral density. So it also makes your bones stronger, no? Myeloblast differentiation and increase in muscle mass. So it can also it can make you muscular, become more muscular. It increases your glomerular filtration rates. It has also an effect on the kidneys, pre-adipocyte to adipocyte differentiation. So this also helps in the maturation of your fat cells. It has an anti-insulin action. In particular, it decreases glucose utilization, increases lipolysis in the liver. Lipolysis among the fat cells, and in the liver, it increases gluconeogenesis. So all these processes will result to what? Increase in glucose, no? So that's why it has an anti-insulin action. And of course, it induces the production of your insulin-like growth factor, or your IGF-1, which functions for growth. And this is your the target hormone for your growth hormone. Okay, what about the problem? No, so if one of the problems for growth hormone or clinical disorders associated with growth hormone is deficiency, when there is not enough growth hormone. Okay, so this is where pharmacology comes in, no? So growth hormone deficiency in children will result to short stature, delayed bone age, and low age adjusted growth velocity. Adults can also experience growth hormone deficiency, and this is manifested as decrease in muscle mass and exercise capacity, decreased bone density. So adults with growth hormone deficiency are at risk, for fractures, impaired psychosocial function, and increased mortality from cardiovascular causes. No? Why is this so? Probably, this is because of the function of your growth hormone in adipocyte differentiation, no? And also, this also has increased lipolysis function, no? Okay, so if you suppress or inhibit growth hormone, so you'll have problem with um, your you'll have trouble with your cholesterol, no? Cholesterol synthesis. So there will be like increase in cholesterol or lipids, no, in your blood, and that can predispose you to increase cardiovascular mortality. Usually for adults, the cause for growth hormone deficiency is due to a functioning or non-functioning pituitary adenoma, no, or tumor in the pituitary gland. It may also be secondary to trauma or related to surgery or radiotherapy of the um, pituitary area. Okay, how do we diagnose growth hormone deficiency? Of course, you look at the height of the patient, especially among pediatric patients, no? You will have a height that is more than 2 to 2.5 standard deviation below normal. There will also be delayed bone age. So how do you determine if the patient has delayed bone age? They do X-rays, no, X-rays of the carpal bones. So radiologists, they can age, no, they can assign an age to your bone. We call it bone age, um, based on the X-ray pattern of your carpal bones. There will also be decreased growth velocity, and the predicted adult height would be below the mean parental height. So what do you mean by mean parental height? So you add the height of the mother and the father and divide it by 2. That's the mean parental height. So if the predicted adult height of the child is, or maybe an adolescent, no, is below the mean parental height, then that would mean that the child has growth hormone deficiency. So I think my daughters had growth hormone deficiency when they were young, no? Because they only got to my height level, no? And my height level is not the mean height of me and my husband's height, no? Okay, but it's too late because they're already past their epiphyses have already, matured, no? Okay, so growth hormone deficiency is also determined by the level of the growth hormone in the blood, no? So aside from the clinical manifestations, you can also check for the growth hormone level. And in this case, this is usually done for adult patients, no? Because in adult patients, maybe the growth hormone deficiency occurred when they're already adults, no? So it might not reflect their height, no? Because it can also happen. So you need to check for the growth hormone level in their blood, and this should give you like less than 10 nanograms per ml of growth hormone following provocative testing. And what is this provocative testing? It uses either insulin or arginine or levodopa, clonidine, or glucagon. So, and in severe form of growth hormone deficiency, you'll have a growth hormone level of less than 5 nanograms per ml. Okay, so how do we treat now? You can give your growth hormone recombinant type, no, of growth hormone, which is exemplified by your somatropin. Okay, so and these are the different brand names of your somatropin: serostim, genotropin, hemotrope, etc. What is the dose? The dose is for children, it's 25 to 50 micrograms per kilogram per day subcutaneously. So it's injected in the evening. Why in the evening? Okay, because we mentioned that naturally or physiologically, growth hormone is secreted in pulses, and it is secreted highest during the evening shortly after deep sleep, no? So to mimic the physiologic increase in hormone secretion, growth hormone secretion, so you need to give it, we inject this growth hormone in the evening. No? The adult dose is 150 to 300 micrograms per day. You know, growth hormone price is about 1,500 pesos per vial of 8 to 10 international units, but this is in micrograms, so you need to convert. Um, it says here that 1 milligram is equal to 1,000 micrograms, and 1 international unit, is equivalent to 330 micrograms. Yes. So that would mean that this 1,500 pesos per vial is only good for about 10 days. No? So if we consider the 300 microgram per day dose, so that would mean that in 1 month, you'll be spending around 4,500. No? So for a normal family, not really rich family, this is already very big, no? An amount only for growth hormone injections of the child. So, well, only those who can afford can really get growth hormone for their children, no? So that's why I heard of a pediatrician who had his child given growth hormone because it was diagnosed as having faltering in growth, no, during the infancy period. So they were injecting growth hormone for up to the closure of the epiphysis. And that would be around up to 18 to 20 years old. No? So imagine, that's why he said the child is multi-million child. Okay, so what will happen if you give this recombinant growth hormone to patients with growth hormone deficiency? Of course, you will see normalization of the IGF-1 levels. So this is used to monitor the initial response and compliance to treatment. Of course, you need to monitor for the long term the height of your patient, and you expect increase in growth velocity within the first 2 years of therapy, no? So you don't expect it uh, very soon, no? And you need to continue giving your growth hormone until the closure of epiphyses. So for adults, how do you diagnose if the patient is having normalization of his or her growth hormone deficiency? You'll have to check on the growth hormone levels, no? So pharmacokinetics of your growth hormone is 70% bioavailable and will require once daily dosing. What about adverse effect of your growth hormone therapy, specifically for children? Well, the adverse effects are rare, but it can cause intracranial hypertension. So you need to do fundoscopic examination at the initiation of therapy and periodically thereafter. Okay, so I hope you know how to use your fundoscope. There's also increased incidence of pediatric tumors. So growth hormone should not be given in the first year after treatment of pediatric tumors, or when the patient is diagnosed to have pediatric tumors. There's also increased incidence of type 2 diabetes mellitus. Why? Because, you know, if you review the effects, physiologic effects of growth hormone, diba, it can increase your serum glucose. Yes, so you need to monitor the fasting blood sugar of your patient periodically. This can also result to slip epiphysis or scoliosis due to rapid growth of your long bones. For adults, adverse effects of your growth hormone therapy can result to peripheral edema, carpal tunnel syndrome, arthralgias, myalgias, okay? And in terms of drug interaction, well, estrogen inhibits, the growth hormone action. So if your patient is in birth control medications or estrogen supplements, then you need to adjust the dose to increase it, no, so that it can maintain um, or sorry, estrogens inhibits growth hormone action. So okay, so if growth hormone is inhibited, then you need to increase the dose of your growth hormone, no, to be able to attain uh, your goal, no, in terms of IGF-1 level and of course clinically, no. Now, what are the contraindications for growth hormone therapy? So these are the following: acute critical illness due to complications after an open heart or abdominal surgery, multiple accidental trauma or acute respiratory failure, active malignancy, proliferative retinopathy or severe non-proliferative diabetic retinopathy. It has also been observed that sudden death can occur, especially among severely obese children who had severe or those who had severe respiratory impairment. Okay, another treatment for growth hormone deficiency aside from your somatropin is recombinant human IGF-1 or your mecasermin. No? So this is specifically indicated for patients with impaired growth secondary to mutations of the growth hormone receptor or post-receptor signaling pathway. So also for patients who develop antibodies against growth hormone that interfere with its action, like in the case of Laron dwarfism. Also for patients with IGF-1 gene defects that lead to primary IGF-1 deficiency. Okay. And although it is less effective than your recombinant growth hormone, no, for impaired growth secondary to your growth hormone deficiency or with idiopathic short stature. Okay, but generally, your recombinant human IGF can be given if the patient does not respond to your usual recombinant GH or your somatropin, no? The dose is 40 to 80 micrograms per kilogram subcutaneously twice daily, maximum of 120 micrograms per kilogram per dose. The BID or twice daily. Adverse effects are the following: hypoglycemia, lipodystrophy. What is lipodystrophy? Okay, destruction of the lipids, no, or the fats. Lymphoid tissue hypertrophy. This lymphoid tissue hypertrophy can result to enlarged tonsils, no, which may even need surgery. Contraindication: you don't give your IGF-1 for those with closed epiphysis, so you don't give it to adults, and those with active or suspected neoplasia. What about the giving of growth hormone releasing hormone? No? Because you know very well that in the regulation of growth hormone synthesis, one of the major stimulatory factors is your growth hormone releasing hormone from your hypothalamus. So there's already a synthetic human growth hormone releasing hormone, and that's your tesamorelin, no? So it increases both growth hormone and IGF-1 levels. However, its clinical effects are primarily to reduce visceral fat accumulation with minimal effects on insulin resistance. So this is specifically approved for treatment of HIV-associated lipodystrophy, but not really for growth hormone deficiency. Okay. So for growth hormone deficiency, you can either give, okay, first is your recombinant growth hormone, your somatropine, and then if somatropine does not work, you can give your IGF-1, but not this tesamorelin. Okay, now what about if there is growth hormone excess? This can also be a problem, no? Now, if epiphyses are not yet fused or not yet closed, then you can develop gigantism or increased longitudinal growth. Actually, some of the basketball players in the US, I think they have gigantism, no? In adults, when the epiphyses have already closed or fused, this can result to acromegaly. No? So acromegaly is manifested with arthropathy or problems with the joints, carpal tunnel syndrome. Carpal tunnel syndrome, you see this when you, for as your one of your adverse effects of your growth hormone um, treatment, no? Generalized visceromegaly, macroglossia, hypertension, glucose intolerance, headache, lethargy, excess perspiration, and even sleep apnea. So how do we diagnose growth hormone excess? Okay, you look at the clinical manifestation, no? If there is very increased in height, too much increase in height beyond the plus 3 standard deviation, or of course for adults you can have those signs and symptoms of acromegaly, so you need to go clinical, plus of course you need to check the circulating growth hormone levels or the IGF-1 levels. So the gold standard for the diagnosis is an oral glucose tolerance test, but this oral glucose tolerance test is different from the ones you used for testing or diagnosing your diabetes, no? So this one, the OGTT here, is the one measured is your growth hormone and not the blood sugar level, no? So in the OGTT test for diabetes, the one measured or the outcome measure is the blood glucose levels, no? But this one is you are measuring the growth hormone level. So what is the normal response? So if you don't have problems with growth hormone excess, there should be suppression of growth hormone level to less than 1 nanogram per ml. So what happens if there's acromegaly? It will fail to suppress growth hormone level, or there will be a paradoxical increase in growth hormone level. So this is the abnormal effect, no? So when you have problem, um, specifically acromegaly. And usually this growth hormone excess is due also to an adenoma or a tumor, which is over-secreting the growth hormone. So this is picture of a gigantism, no? So you have the here the mother and the son, and these are the pictures for your acromegaly. No? So you have the enlarged flat bones here in your carpal bones, so that's why you can have carpal tunnel syndrome. This is macroglossia and arachnodactyly. No? Although arachnodactyly is also a manifestation of what? Marfan syndrome. No? Okay, so how do we treat growth hormone excess? Because the problem is usually in an adenoma in the pituitary gland, particularly in the anterior pituitary gland. Well, you need to do transsphenoidal surgery. Okay, so if the lesion is still small, you can do surgery. If it's already big, more than 1 cm lesion, which we call a macroadenoma, then you may need to do radiation therapy or the giving of drugs that inhibit the growth, inhibit the growth hormone secretion or action. In terms of microadenoma, surgery can give you an 80% cure rate, no? So if the lesion is just less than 1 centimeter in size, okay? As far as radiation treatment is concerned, compared to drugs, it's been said that radiation therapy gives a lot of complication. That's why drug therapy is more preferred than radiation therapy. So under drugs, you can give your somatostatin analogs. So remember that somatostatin is produced by your hypothalamus to inhibit the secretion of your growth hormone. Or you can give a growth hormone receptor antagonist. So this is how transsphenoidal surgery is being done. So this is the job of a neurosurgeon. Okay, if any of you wants to be a neurosurgeon in the future, so there is this direct route, no, from um, the infranasal area, no, towards the pituitary gland, no, without um, damaging or entering or slicing through the brain tissue. Okay, so this is another way of looking at transsphenoidal surgery. There's a new mode of transsphenoidal surgery, and that's endoscopic, no? So you don't need to flap open the inferior nasal area so that you can reach the pituitary gland, no? You can just insert your endoscope, no? And then the surgeon can already remove the pituitary gland. No? So this is a newer approach, no, for transsphenoidal surgery. Okay, so if you're going to use drugs, no, to treat excess growth hormone, then you can use one of the somatostatin analogs. Okay, one, you have your octreotide, marketed as sandostatin. Sandostatin is the brand name, one of the brand names. Okay, the dose is 100 micrograms subcutaneously 3 times a day. And then 100% bioactivity, peak effect 30 minutes, T half-life is 90 minutes, so duration of action is 12 hours. Well, they give it TID so that, they don't really go below the actions. The action can be sustained, okay? There's also this octreotide LAR, which is a long-acting, slow-release octreotide with preparations of 10, 20, and 30 milligrams. It's given once every 4 weeks, no, because it's long-acting. And there's also this lariotide, another somatostatin analog, which efficacy is similar to the octreotide long-acting, no? And the last is your pasireotide, which binds to multiple somatostatin receptors. So actually, it's theoretically better than your octreotide and lanreotide, no? So the goal of treatment for your somatostatin analogs in general is to decrease the growth hormone levels to less than 2.5 nanograms per ml after your oral glucose tolerance test, or to normalize your IGF-1 levels. Adverse effects, gastrointestinal, 50%, some or 25% may have or may develop gallbladder sludge or gallstones. And this can also lead to hypothyroidism, no? Because it can also, somatostatin analogs can also inhibit TSH, no? Decrease insulin secretion would reduce insulin resistance. Yeah, this is a balanced effect, no? Even if it decreases insulin secretion, it reduces it also reduces insulin resistance. So, okay lang. But there is this specific somatostatin analog like your pasireotide, which will give you more problem with glucose tolerance. So, if your patient is diabetic at the same time, then you don't give pasireotide, no? For his growth hormone excess, no? So you choose from your octreotide or lanreotide. Yeah, it may also block other hormones, growth factors, cytokines. Okay, so aside from the somatostatin analogs, you can also give your growth hormone antagonist. Okay, so this is exemplified by your pegvisomant. So pegvisomant is a recombinant pegylated variant of your human growth hormone. Okay, so when we say pegylated. So when we say pegylated, it means that this peg stands for what? Polyethylene glycol, no? So it means that it has a polyethylene glycol um, portion in its structure, no? So, and that can increase the half-life of the drug and reduces its immunogenicity. Okay? So that's why it can be given like just once a day, no? So, it is a growth receptor antagonist. No, because it looks similar, no? It's a variant of your human growth hormone. Okay, and it is for your specifically indicated for acromegaly. The dose is 40 milligrams subcutaneously as the loading dose, then decrease it to 10 milligrams per day and adjusted based on the serum IGF-1 level. This should not be used for patients with liver disease, so you need to monitor the transaminases. This can cause high lipohypertrophy at injection sites and may also increase the growth of growth hormone secreting adenomas. So this can be used also for patients who do not respond to your somatostatin analogs, or it can also be given as adjunct or additional drug to your somatostatin. Now let's go to your prolactin. Okay, so prolactin is 23,000 Dalton or 23 kilodalton protein or polypeptide composed of your 199 amino acid with 3 intramolecular disulfide bonds. No? So remember that growth hormone is 22,000. Your prolactin is 23,000. So they are kind of similar in structure. That's why they're grouped together. So it is particularly synthesized by the lactotropes in the anterior pituitary gland, and the synthesis and secretion starts on the 5th week of gestation. Okay, so it's pregnancy, no, that stimulates the production of your prolactin. Of course, in preparation for lactation, no. So there's an increased rise during pregnancy and peak at term and decline thereafter unless the mother breastfeeds the child. No? So the stimulus is the suckling and breast manipulation in nursing mothers. We mentioned pregnancy. There's also this thyroid releasing hormone, no, and your VIP, vasoactive intestinal peptide. Okay, so this is the regulation of prolactin secretion and action. So you have your TRH there as stimulatory, dopamine as inhibitory, no? And then, yeah, it's the suckling. Oh, yeah, these are already mentioned. Okay. Now, what is the problem with prolactin secretion? So if there is again an adenoma or a tumor in the anterior pituitary, this can result to prolactinoma and hyperprolactinemia, or increase in the amount or in the production of prolactin. So this can be manifested among females with galactorrhea, amenorrhea, and infertility. So what is galactorrhea? So it is increased secretion of milk, um, unrelated to normal milk production. So meaning that the mother or the woman um, is not lactating, no, but there is milky nipple discharge, no. This may also be associated with larger breast, but not always, no. In men, so hyperprolactinemia can also occur in men. This can result to loss of libido, erectile dysfunction, and infertility, no. So practically it this condition makes men useless to their women. Anyway, so the diagnosis is through MRI, magnetic resonance imaging, and therapeutic options are again transsphenoidal surgery, radiation therapy, and when you need drugs, you can give your dopamine receptor agonist. So if you remember the previous slide, okay, dopamine is inhibitory to prolactin. That's why if you give your dopamine receptor agonist, it can suppress prolactin production by activation of the D2 dopamine receptors, which will increase the tumor size. And this is the drug of choice for most patients. Okay. What can prolactinoma do? No? So for big lesions like macroprolactinoma, so macroprolactinoma are those lesions that are more than 10 millimeter in size. No? So it's the diameter of the tumor. So this can compress the optic nerves, no, which is very near your pituitary gland, no. So that can result to bitemporal hemianopia. So you cannot see on the periphery. Okay, so medical management for your hyperprolactinemia is of course the giving of your dopamine receptor agonist. And under this, you have your bromocriptine, your carbidolin, and quinagolide. So bromocriptine is, the brand name is Parlodel. Carbidolin, brand name is Dostinex. Both are ergot derived. So what's ergot? Ergot is a type of fungi, no, from the genus Claviceps. So that's the source of the drug, no, bromocriptine and your carbidolin. So carbidolin is more potent than your bromocriptine, but the one that is more available in our setting is Parlodel or your bromocriptine. Quinagolide or Norprolac is non-ergot, no? Non-ergot derived. So for bromocriptine, okay, it activates your D2 receptors to inhibit spontaneous and TRH-induced release of your prolactin. So it can normalize prolactin level in 70 to 80% of cases, can decrease tumor size in more than 50%, but if you stop it, the tumor can recur. So adverse effects, nausea, vomiting, headache, postural hypotension, less frequent nasal congestion, digital vasospasm, CNS effects of psychosis, hallucinations, nightmares, and insomnia. I have tried taking Parlodel, but not because I had hyperprolactinemia, but it was because of postpartum breast engorgement. No, um, unfortunately, I failed in breastfeeding my daughter because I don't know why. I really wanted to do it, but my daughters would not just suck on my breast, no. So I've tried everything already. So because they're not sucking on my breast, so milk is not going out. Of course, my breasts were just getting bigger and bigger, and it's already up to my axillary region. It's very, very painful, no? So I really needed to call a friend, Dr. Recha. Ren, what can I do? This needs to stop. So she prescribed me with Parladel, just a low dose Parladel, no, just 1/2 tub twice a day for 3 days, and lo and behold, in one day my breast size already sunk significantly, and the pain is gone. Yeah, so it's magical. No? The effect of bromocriptine was magical for me. So to avoid the side effects of your bromocriptine, you can start at a low dose, no? So low dose of 1.25 milligram at bedtime. After 1 week, increase to 2 times daily, and then gradually increase every 3 to 7 days up to 5 milligrams twice daily, or until prolactin levels becomes normal, no? So if you give it a much higher concentration or dose, it can be a treatment for acromegaly. Why? Again, your your prolactin looks very similar to your growth hormone, no? So that's why if this dopamine works, or dopamine agonist works for suppressing your hyperprolactinemia, then it may also suppress growth hormone secretion at higher concentration. Still, at much higher concentration, can be a treatment for Parkinson's disease, and safe. It can be safely used among pregnant women. Carbidolene has a longer half-life and higher affinity and greater selectivity to D2 receptors. So it's actually the preferred drug for hyperprolactinemia with greater efficacy and lower adverse effects. The dose is 0.25 twice a week, or zero point 0.5 milligrams once a week. May increase it once every 4 weeks. Doses of 2 milligram per week or less can already normalize your prolactin levels in 80% of patients. At higher doses, it can be used in some patients with acromegaly, again, because of the reason mentioned, and in conjunction with somatostatin analogs. So adverse effects less than that of bromocriptine, but it is known to be linked to valvular heart disease at high doses. Now let's go to your glycoprotein hormones. So these are your TSH and your gonadotropins. So for your TSH, this will be taken care of by the anti-thyroid drugs. It's one chapter also, it's one lecture. So I will just focus on the gonadotropins. So we have the gonadotropin releasing hormones and your gonadotropic hormones. So LH, FSH, and HCG, these are your gonadotropins. And the physiological effects of this in men, your LH acts on testicular Leydig cells to stimulate de novo synthesis of your androgens, primarily your testosterone from cholesterol. No? And your testosterone is of course required for gametogenesis and for the maintenance of libido and secondary sexual characteristics among men. Can also, on the other hand, FSH can act on Sertoli cells, no, which will stimulate the production of proteins and nutrients for sperm maturation. So men needs both your LH and your FSH. And this FSH-LH pathway works through your GPCR, GS cyclic AMP pathway. Okay, in women, FSH stimulate the growth of the developing ovarian follicle and induces expression of your LH receptors on theca and granular cells. FSH also regulates the activity of aromatase in granulosa cells, which will stimulate the production of your 17B estradiol. On the other hand, LH acts on the theca cells to produce androstenedione, which is the precursor of your ovarian 17B estradiol. And you also need your LH for the ovulation, no, for the rupture of the dominant follicle, and for the synthesis of your progesterone by the corpus luteum. No? So FSH for ovarian growth, LH for ovulation. So therapeutic uses. Let's start first with your GnRH. This is your gonadotropin releasing hormone. Okay, so this gonadotropin releasing hormone, the mechanism of action is through your GPCR, GQ11, PLC, IP3 calcium pathway. Okay, so there's a synthetic GnRH in the form of your gonadorelin acetate, marketed as your Lutripulse, which will stimulate gonadotropin release. Okay, there's also this gonadotropin releasing hormone agonist. Okay, under these you have your leuprolide, goserelin, histrelin, nafarelin, and your triptorelin. So they are long acting, and they are used to diagnostically differentiate between GnRH dependent and GnRH independent precocious puberty. So particularly your leuprolide is used for this. This can also be used for pharmacology castration as management for precocious puberty. Come to think about it. Why management for precocious puberty when it is a GnRH agonist? Diba? GnRH agonist is supposed to stimulate the production of your gonadotropin because it's an agonist. Similar sana to your gonadorelin acetate, which is a synthetic GnRH. No? So it will stimulate gonadotropin release. But here, it's used for pharmacology castration. What could explain this? It's even used for palliative treatment for hormone-responsive tumors, endometriosis, uterine fibroids, acute intermittent porphyria, priapism. It's also used to suppress LH surge. Why the opposite? Mhm. Yes, because it is long acting. Okay. And long acting GnRH agonists may increase the hormone levels transiently. However, in the long run, what will happen is it will cause down regulation of your GnRH receptors. Remember physiology? So it will cause down regulation because it's long acting through the GPCR pathway, no? So that's why it can be used to suppress, no? For long-term use, it can be used to suppress hormone production. Okay? But this problem of transient increase in hormone levels can be managed by giving anti-androgens, no? So anyway, it's just in the initial phase. Adverse effects of your GnRH agonist, you can have hot flashes, decreased bone density in both sexes. Like, it seems like, you know, signs and symptoms of menopause. No, because you are you are inhibiting gonadal steroidogenesis, no, or the production of these hormones. Can also cause vaginal dryness and atrophy in women and erectile dysfunction in men. Treatment for endometriosis and uterine fibroids are limited to 6 months only because of these above adverse effects, and it's contraindicated among pregnant women. Now, what about your GnRH antagonist? Oh, this one is really an antagonist, no? So these are your Ganirelex and your Citrorelex and also your Degarelex. So for your ganirelax and citrorelax, they suppress LH surge also, similar to your GnRH agonist, no? And prevents premature follicular luteinization in ovarian stimulation protocol. So they use this for what? For in vitro fertilization, so that they can control, no? They can control the LH surge, because you know that LH surge um, will occur around 36 hours before ovulation. Um, it can also be used for PCOS, no, or polycystic ovarian disease. And off-label use also includes your endometriosis and uterine fibroids, but it's contraindicated among pregnant women. Compared to, because it's the effect of your GnRH antagonist is similar to your long-acting GnRH agonist, it seems that the GnRH agonists are more favored. Why? Because for reasons that cannot be explained yet at this moment, GnRH agonists work better than GnRH antagonists in suppressing LH surge and for all the other indications as well. What about your Degarelix? Degarelix is specifically indicated for treatment of advanced prostate cancer. No? So it suppresses testosterone level to 50 nanograms per DL or less, no? Which is equivalent to medical castration. It also lowers prostate-specific antigen more rapidly than your GnRH agonist without an initial testosterone surge. Okay, so what about your gonadotropin? So these are your FSH, LH, recombinant human LH. There's also corresponding drugs, no, um, that are in the form of these gonadotropins, no. So they are used for diagnostic purposes like pregnancy testing, specifically for your HCG, no, timing of ovulation. So you can test for urine LH, no, which can help predict the time of ovulation, no, because ovulation occurs approximately 36 hours after the LH surge, or 10 to 12 hours after the peak of the LH. So this can facilitate the timing of sexual intercourse to achieve pregnancy, or the timing of the harvest of follicles. And it can also help in the localization of endocrine disease. Therapeutic uses can be for male infertility and cryptorchidism. Okay, the details you read in your book. Now let's go to your posterior pituitary hormones. Okay, for your posterior pituitary hormones, you have your oxytocin and your ADH, or your arginine vasopressin. But your ADH uh, is will be discussed to you, or was already discussed to you in regulation of renal function and vascular volume. That's chapter 25 of your book. So I will not discuss on this anymore. So I will just focus more on oxytocin. Okay, so remember this picture. So this is the production of your oxytocin and vasopressin directly from your hypothalamus, no? So they are just stored and secreted in the posterior pituitary. Okay, so what is oxytocin? It's peptide, no? So differs from vasopressin only by 2 amino acid, and it is secreted by the posterior pituitary gland. So this is the structure of your oxytocin and your vasopressin, no? So see the different amino acid, only 2 of them, no? Okay, physiological roles of your oxytocin. For the uterus, it stimulates the frequency and force of uterine contraction. Okay, through the GPCR, GQIP3 calcium pathway. In the breast, it will cause milk ejection. So if prolactin is for milk production, oxytocin is for milk ejection. And it is estrogen dependent, no, because estrogen increases the expression of your oxytocin receptors, while relaxin is inhibitory to your oxytocin secretion. Progesterone also antagonizes the stimulant effect of your oxytocin. Okay, so in the breast, for milk ejection to occur, there should be suckling or mechanical manipulation of the breast, no, which will result to contraction of the myoepithelium that surrounds the alveolar channels of the mammary gland, which forces the milk from the alveolar channels into the large collecting ducts and ready for the suckling of the infant. Oxytocin also increases local prostaglandin production, which further stimulate uterine contraction. In the brain, it is a CNS regulator of trust, and in the autonomic nervous system, it is linked to anxiety and fear. Um, it is noted that um, with the presence of oxytocin, there is decreased activation of some parts of the brain in response to stress. So, meaning that oxytocin can be a stress reliever or anti-stress. It has anti-stress effects. Okay, clinical uses of your oxytocin, induction of labor. So, it is administered as an IV drip at a dose of 1 milli-international units per minute and titrated as needed. Now, if at 40 milli-international unit per minute, there is still no significant increase in uterine contraction, higher rates are unlikely to be successful. So you have to stop there. No? So it's useless. Now, the danger for inducing labor, because you're inducing the uterine muscles to contract, no, of course, is the risk for uterine tetany. Too much contraction of the uterus can develop. What do? You just stop the infusion, and because oxytocin has a short half life is only about 3 minutes. So in a few minutes, the effect of the oxytocin will be gone. No, so this can be corrected, or uterine tetany will stop. No? At a dose of more than 20 milli-international units per minute, there can be decreased water clearance by the kidney. Why? Because again, oxytocin and vasopressin, or your ADH, they are very similar in structure, no? With the exception of the two amino acids. Now, if you give hypotonic fluids like D5 water and it is infused rapidly, um, while giving oxytocin, or sometimes it is used, D5 water is used to combine, no, to infuse oxytocin. Like oxytocin is incorporated to D5 water. If it is infused rapidly, it can give you the risk of water intoxication, which can result to convulsion, coma, and even death. So, well, it's preferred that oxytocin should be infused using normal saline solution instead of D5 water, because normal saline is isotonic to plasma. So clinical uses of your oxytocin is augmentation of dysfunctional labor. So the dose is usually does not exceed 10 milli-international units per minute. So if the labor is not progressing well, then you can augment it by giving your oxytocin drip. It can also be used for prevention and treatment of postpartum hemorrhage. So it is a must, no? It is given to all women right after the delivery of the fetus, no? So it's given IM, 10 international units IM, one dose within 1 minute after the delivery of the fetus, not after the delivery of the placenta, no? that is to prevent postpartum hemorrhage. Or it can be given 20 international units in 1 liter of IV fluid at 10 ml per minute until the uterus is contracted, and then decrease to 1 to 2 ml per minute. There is also what we call an oxytocin antagonist, no? This is exemplified by your atosiban, which is an oxytocin receptor antagonist. So it is used as tocolytic therapy for established preterm labor. In preterm labor, there is premature contraction of the uterus, and we don't like that. No, of course, no. So what can you do? You can give tocolytic therapy. So tocolytic will inhibit uterine contraction, and one of these tocolytics is your atosiban or your oxytocin antagonist because it can antagonize the action of your oxytocin. Other tocolytics that are being used to prevent preterm labor or to control preterm labor are the following: beta-adrenergic receptor agonists like your terbutaline, salbutamol, magnesium sulfate, your calcium channel blockers, cyclooxygenase inhibitors, and your NO donors. So this is now the summary of the drugs that mimic or inhibit hypothalamic and pituitary hormones. So we have discussed most of them, I think with the exception of your vasopressin. Yeah, these are your vasopressin. Yeah, practically all, no? So examples of your FSH, LH, and FSH, you have for mixed LH, FSH, you have menotropins. LH, you have your lotropin. And your FSH, you have your folitropin. Okay, so this is already my last slide. Thank you very much for your attention.